All of you. I'm presenting case of 2.5-year-old male child, Nawaz Khan, resident of Jalgaon, Maharashtra, came to us with chief complaints of pain in the lower back for last 5 months and deformity in lower back for last 3 to 4 months. Patient was apparently all right 5 months back when patient had pain in the back. Pain was insidious in onset, which gradually.
This is the patient.
This, yeah.
Is the patient complaining or is the parents saying?
Informant is aunt, sir. Aunt is saying.
Does the patient speak at all?
Patient speak few words, sir.
Few words.
Yeah. Pain was insidious in onset. It was localized to back. It was dull aching type, which gradually.
Is the child walking?
Yes, sir.
Still walking?
Yes, sir. With support. It gradually increased over the period of 1 month. It was associated with evening rise of fever, and pain was more in the night as compared to daytime. The informant also
all these points which you are saying.
Yes.
How has the informant realized all this?
Pardon, sir?
For a 2-year-old child, all this detailed history which you are giving.
Yes.
How has the informant told you that the patient has more pain in the night? Means what is the behavior change? You understand what I am trying to tell you? You are presenting a case in a 2-year-old child, right?
Yes, sir.
And you are presenting a history as if it's an adult patient telling you about his complaints that I have fever with evening rise. How do you come to know all this?
Sir,
has the informant taken temperature in the evening?
No, sir. Informant is telling that patient has increased body temperature as they noticed more in the evening time, and patient used to cry in the night time more. He has more cries in the night time as compared to daytime. The informant also noticed the deformity in the lower back for last 3 to 4 months, which gradually increased in size, for which patient was taken to a private practitioner in Jalgaon, where they have told to do X-ray, MRI, and medication was started. According to informant, the medication was given in the empty stomach, which changed the color of the urine to the orange color. And patient was also given a belt to wear. Patient took this medication for a period of 2 months, but pain and deformity, according to informant, that is the cry of the patient and the deformity gradually increased. So they again went to the same practitioner, from where he was referred to higher center for further management. There is history of weight loss. There is history of evening rise of fever. Mother of the patient is pulmonary tuberculosis positive, and she is on treatment currently. Patient has more episode of crying in the night. There is no history of the weakness in the lower limb. There is no history of any bowel bladder involvement.
How do you know that?
Pardon, sir?
Is the patient toilet trained? Is the patient toilet trained? How do you know that the patient has bladder or bowel involvement?
For latrine.
Don't counter. See, in a 2-year-old child, you can't talk about bladder and bowel. Have you asked?
Yes, sir.
What has they told you? The patient must be always pissing and shitting in diapers. How can you talk about bladder and bowel control in a 2-year-old? See, when the examiner is countering you aggressively, go on the back foot. Okay, don't charge back at me. Okay? If you had a 2-year-old child, is the child going to tell you that I have lost bladder and bowel control?
No, sir.
Then, all your history is being presented as an adult koch spine history. You are presenting a pediatric TB spine patient. So reframe the question and history in your mind. And you are not presenting a 7-year-old child or a 9-year-old child or a 11-year-old child. You are presenting a poor 2-year-old child who must have got this infection 6 months back. At 18 months, which child is able to tell you whether he has meningitis, he has abdominal discomfort, whether he has hip pain? All his symptoms will be same. He was able to walk, he is now not able to walk. He is uncomfortable, he is not eating any longer, he is more irritable than before. Yes, deformity I can understand, but rest of your history is all fictitious. You've created it to write down the long case. I don't believe that a mother is going to tell you that the patient now not having bladder bowel control. Which 2-year-old child can you make out that the child has got bladder bowel control?
On past history, patient had a surgery at the 3rd day of the life for query intestinal obstruction, details of which is not available. On personal history, diet of the patient is mixed. In family history, there are total 6 members in the family. Father is only earning member in the family. He is a laborer by occupation, and mother has history of pulmonary tuberculosis and she is on treatment. On birth history, it was full term normal vaginal delivery. Birth weight of the patient was 2.25 kilograms. There is history of NICU admission for 4 months for the surgery at the 3rd day of the life.
Is there a scar of surgery of that surgery?
Yes, sir.
Where is it?
In the abdomen, in the hypochondrial and the.
What is that surgery done for? Commonest cause of surgery is what at that age? Intestinal obstruction, you said, no? And the surgery scar is in the hypochondrial.
Yes.
What is the commonest surgery that takes place in that age group, in a child, in a neonatal child?
Pyloric stenosis.
That's classical at that age.
Yes.
So you actually can say confidently, surgery has been done for pyloric stenosis. Yeah? There's no intestinal obstruction, it's a gastric obstruction. Okay, then?
On the local examination, sir, midline furrow is obliterated at the lumbar level. Deformity is present at the lumbar level. Paraspinal fullness is present at the lumbar level. Skin over deformity appears to be normal. There is no there are no scar, sinuses, and fistula on the back. On examination from the front, there is scar mark of longitudinal scar mark present over the hypochondrial region of previous surgery, which is healed by primary intention.
So one thing, so you had a little bit of a discussion with him. The important thing for everyone is that if that happens, don't let it fluster you. You have to carry on with the same confidence. So what has happened after that conversation with him about that bowel bladder, suddenly you started off very well and now you're kind of, sort of fluttering a bit. So in the exams, that should never happen. You should not get, you're going to do orthopedic surgery, you're going to be faced with problems in the theater, you have to manage them. So if you have a problem in the exam like this, you just go on with the same confidence and the same sort of fluidity. Don't let it affect you because it can sort of spoil your entire exam otherwise.
So it's difficult, but this is what is required. So don't mind me speaking.
Yeah, and sometimes the guys, the examiners who sort of are the most aggressive are actually the most lenient with the marks, and the ones who are very quiet will be the ones who will fail you. Okay.
On palpation, findings of inspection were confirmed. Findings of inspection were confirmed. Local temperature is not raised. Tenderness is present over the deformity and the paraspinal area. Deformity is angular kyphosis, and level of the deformity is L2, L3 level. There is no other palpable deformities or fullness in the back. On neurological examination.
Have you seen the X-ray of the patient?
Pardon, sir?
Have you seen the X-ray of the patient? How can you confidently say this is L2, L3?
Sir, I have palpated the level. The highest point of the iliac crest is at the L4 level, and from where I counted, and it is just above that.
What I am trying to tell you, this is severely deformed spine. Your normal parameters and markings won't be matching. So you should say it is at dorsolumbar at upper lumbar level. Don't give accurate pointing answers that it is at L2, L3 level. It shows that you have seen the X-ray or you have seen the MRI.
On neurological examination, bulk and nutrition is bilaterally equal. tone is bilaterally symmetrical. Power in the hip, knee and ankle is greater than 3 plus by 5.
The child cooperating for that, are you able to make out?
Sir,
See, again, you are seeing a 2-year-old child. It's very difficult to comment on power like that.
sir,
How do you comment on a 2-year-old child's power?
sir, I asked the mother to ask him to raise his lower limb against the gravity. He is doing that. So it is 3 plus by 5.
So in a smaller child, it's very important to look for regression of milestones. So you ask the, parent what was the child doing and have you noted any regression? So if the child was walking and has stopped walking, if the, so that is a very important point in a child like this, where there is a thoracolumbar spinal deformity, and you have to find this out, because it's very important that you question, especially in a smaller child. Now, likelihood is in the exams you'll have an older child, where this will not come in. And of course, don't sort of apply the adult to a very small child, like the history part.
For example, whether the child could get up from sitting position, whether his gait has changed, those become more important. Power is not easy to assess. So if the mother says earlier walking, now he's crawling, he can't get up on his own because of pain or deformity, that is an important finding.
So you will be pardoned for not really commenting on the exact power in a child. So don't get into that zone. Like Dr. Arjun said, you will not get a 2-year-old child with Koch spine. It's impossible to, it's real bad luck. And if you get, you will anyway pass. So don't worry.
Reflexes in the knee and ankle are normal. Plantars are flexors. Clonus is absent.
Up to what age are plantars extensor in a child?
Sir,
Normal.
up to walking age, plantar is extensor, that is up to 1 year of the age. After that, pyramidal tracts takes over and it becomes flexor.
So the tip of the spinous process, what do you feel? Kyphotic deformity.
Yes, sir.
What level is that? In what vertebrae? Is this the collapsed vertebrae or the vertebrae above normal vertebrae or normal vertebrae?
It is most probably vertebra above the collapsed spine.
So what is gibbous and what is kyphos? Do you know the difference? This was asked in our exam when we were doing TB spine. Knuckle deformity, gibbous deformity and kyphos deformity. What does it mean?
Sir, when single vertebra is involved, then it will point out like a knuckle of our fingers. So it is called as knuckle deformity. When more than 1 but less than 3 vertebrae are involved, it is called as gibbous deformity. And when more than 3 vertebrae are involved, it is called as the.
Very good, very good. Excellent, excellent.
What do you want to do for this child now?
Sir, I would like to investigate this child in the form of X-ray of the whole spine, AP and lateral view.
No blood test? You don't want any blood tests?
First, I want to have a look at the X-ray. Then I will ask for blood test in the form of complete blood count with ESR. As patient has a history of contact, I will ask, and he is on anti-tubercular drugs. So I'll ask for the LFTs and RFTs.
Don't read the X-ray. Yeah.
So this is the X-ray of the whole spine, AP and lateral view. In the lateral view, it shows the complete collapse of L3 vertebra along with decrease in disc space between L2 and L3 vertebra with kyphotic deformity. In the AP view, there is there is almost complete collapse of L3 vertebra.
Anything else on the lateral view?
Loss of lumbar lordosis in the.
What about the dorsal spine?
Any other lesion is there? Only one lesion.
Pardon, sir?
Any other lesion? Is there any other lesion in the vertebrae or there's only
So
one?
there is no evidence of skip lesions.
Not looking like any involvement of dorsal spine.
What about the psoas shadow? Is there any cold abscess? Can you see any shadows on the X-ray?
APV, it doesn't appears to be.
Actually, you can. So couple of things on the X-ray. So you have to ask for an X-ray of the whole spine, AP and lateral view. Whole spine, just like rightly said, because you want to obviously, you'll obviously focus on that obvious kyphotic area, you know, where there is destruction but you need to look for skip lesions, okay? It's very important that you look for the soft tissues. So in the thoracic spine, you should look for any fusiform abscess, etc. And in the lumbar spine, like you can see actually the right side psoas shadow. You can actually make it out here. You know, you see that? There is a shadow, all right?
Yes.
So you have to look for it on the lateral, and obviously you should have a well-prepared abdomen, but it's there, okay? So look for it. Also look at the hips, etc. You know, because somebody may have a psoas abscess and may have a hip flexion contracture, okay? And you need to know that the hips are normal and the hip is not affected, right? So don't focus on one area. I mean, kind of be broad in your evaluation. What are the spine at risk signs?
Pardon, sir?
Spine at risk signs.
Sir, there are 4 spine at risk signs. Facet joint dislocation, lateral translation in the AP view, retropulsion, and toppling sign. Toppling.
So what is the significance?
Sir, when spine at the risk sign are more than 2, there are obvious progression of the deformity, and when all the 4 signs are present, then these childs are high risk candidates for surgery.
For?
High risk candidate to go for surgery.
No, high risk for the presence of more than 2 spine at risk signs is an indication of
Progression of the deformity.
correct progression, not surgery. So it is, if you have more than 2 or 3 signs, if you have 2 signs or more, then it's like it depends. So there's so much predictive value of this leading to a significant kyphosis as the child ages, right?
Yes.
Okay. So what do you want to do now?
Sir, I want to get MRI of the dorsal lumbar spine with screening of the whole spine.
Okay. Anything simpler to start with? Suppose you don't have access to the MRI right now.
Sir, I would like to do UHG abdomen to look for any collection in the sauce.
Okay. So you'll at least have some basic idea. So suppose you're not in a very big facility, you don't have an MRI available. At least sonography is available everywhere. You can at least get a sonography. You know that the lesion is in the lumbar spine. You know there's a likelihood of there being a psoas abscess. So you can at least understand what's happening, right?
Yeah.
So this patient has already received AKT, you said.
Yes.
Why is the patient not responding?
Sir,
Do you think the patient is not responding? Do we have any parameters by which we can say whether the patient has responded or not? What I mean is the medical disease still active, or this is like a part of the deformity because of which the patient is painful?
I'm not getting it.
So there are 2 parts of tuberculosis of the spine, right? There is a medical disease and there is a surgical disease. So is the patient painful because of the medical disease? Is the patient painful because of the surgical disease, or both? Means is the disease active?
Sir, if we have the previous X-ray, we can compare the progression of the deformity, progression of the kyphotic angle, and it will tell whether the kyphotic angle is progressive or not. Secondly, if we have access to MRI or we can see the abscess, so we can compare both the MRIs and we can tell whether abscess size is reducing or it is increasing.
So I think 2 basic things would be clinical and ESR. That is what we do, right? All the symptoms with which the patient presented should start abating, the count should improve, the ESR should start decreasing. That is the clinical signs of improvement. But I think your patient is not showing any signs of improvement. No? The
Yes.
child is worsening.
Yes.
So what do you suspect then? Why is the child worsening in spite of receiving AKT?
Sir, most probably a child would have drug-resistant tuberculosis.
How can you find out? Because the child's mother already has tuberculosis.
Sir, we can, if we find anything on the UHG such as source abscess, we can send it for investigations, gene expert, TBMGIT, along with culture and histopath. So
We can also track the mother's
yes,
reports, whether she had a gene expert done or not.
yes,
Whether she is on the extended spectrum AKT or on primary AKT.
yes.
So what is primary drug resistance and what is secondary drug resistance?
Sir, primary drug resistance is patient getting drug resistant tuberculosis in nevo. Means from beginning he has the drug resistant tuberculosis. But
Very good.
the secondary drug resistant tuberculosis is patient is when a patient is initially prone to be respondent to the primary drugs, and later on it turns out to be drug resistant tuberculosis.
So what will you offer to this child now? He's 2 years old.
Yes, sir.
This is the X-ray picture.
Yes.
He is no neurological deficit.
Yes.
So what treatment will you offer him? Besides the AKT, AKT is a medical management. What orthopedic treatment will you offer this child?
Sir, initially, as the patient don't have any neurological symptoms, apart from AKT, I would like to brace the child in the form of total contact brace, total contact thoracolumbar-sacral orthosis, and we would have the regular follow-up, say, for
You
the
think
same.
he will comply with the brace? Suppose he doesn't wear the brace, or the parents can't understand the brace. What will you do?
Means will you offer surgical treatment?
Suppose he doesn't wear a brace. Mothers can't put a brace. They are from the low socioeconomic status.
Okay.
Something we were doing in the past, olden days, what do you do to this child?
Bed rest, bed rest.
But how? So you can put a plaster also, no? You can put something like the scagliotic cast, which goes from the dorsal lumbar spine to the hips, both the legs, like a pantaloon cast. And let him be on rest. Let the lesion heal, let the medical treatment take over. Because brace he may not wear. Okay. So that is what we would do in the past, because he doesn't need surgery. He's too young.
Yes.
So what are the criteria for surgery? When will you offer him surgery, this child?
Sir, when there is neurological worsening, when a patient is on AKT, there is no if patient initially had neurological say neurological deterioration and he is not improving after taking 4 to 6 weeks of AKT, appearance of new neurological symptoms when patient is on AKT, and when patient present with complete paraplegia.
So, only neurology is the way to the surgery. What about progressive deformity or potential for progressive deformity?
And pain, unrelenting pain.
Pardon, sir, I did.
So, you're saying only neurology is the criteria for you for the child undergo surgery. That means if there are no neurological symptoms, this child may never need surgery?
No, sir. If the kyphotic angle is worsening and it would be greater than 60, then we can have a patient for surgery.
So, will you wait for that to happen or will you preempt it if you have a suspicion that this child is a likelihood to develop?
Sir, on the X-ray there is only toppling which is present, and
So, how many levels are involved here?
sir, 2 levels are involved.
Okay. Yeah, Arjun?
So I think it's very important that you look at the X-ray. So this actually doesn't have toppling, but if you see L2 and L3, you see that the discs are, they're sort of flat. So they're resting on each other. So when they're resting on each other, it's very unlikely that this is going to topple. But if sort of the, the top of 2 is sitting on 3, with a bad angulation, that is the one which will likely progress, right? So here, if you look at this X-ray, you see the end plate, of 3, you see the end plate of 2, and you see it's kind of resting on each other.
Yes.
So this is the one which is likely to plateau out, all right, versus if it was sitting the other way. The other thing is the lumbar lesion. A lumbar lesion is again less likely to very, very badly progress if it's here. The problem would be if it was junctional. Junctional area will be bad, Again, cervicodorsal will be bad. And it is important that you sort of measure the key angle. So you have to measure the key angle serially. Again, there's the good thing here is there's only one body involved. So if it was 2 bodies or 3 bodies, then you know there's widespread destruction. Those are the ones who are likely to progress. So if you actually extrapolate the sort of spine at risk signs, they actually extrapolate to whatever we are talking, sort of more than 1 or 2 bodies, when there is significant angulation, when there is toppling. Usually with one body lumbar, you can afford to watch. So you don't want to over-aggressively surgically treat all patients either. It is important that you sort of understand what is happening. But broadly in your mind, you should remember that the ones which are junctional are likely to progress, 2-3 bodies likely to progress, and again where there's significant angulation with toppling likely to progress, right? So, but that would be the other indication for surgery, like what Dr. Arujas is asking, apart from neurology, instability. So spinal instability or very high risk of progression would be an indication for surgery.
Yes.
We still talk about that Shanmukh Sundaram and Rajashekharan's classic, that risk of y equal to a plus bx.
Correct,
and
yeah,
all that.
Yeah. So remember that all this information has come from the MRC trials. So we don't actually have anything now, but everything that has been written is from the old MRC trials. The MRC trials basically had 3 groups. There was one group in Chennai, okay, which Dr. Shanmukha Sundaram sort of did, and which Dr. Rajashekharan has written his paper from. There was one group which was in Hong Kong, okay, Hodgson, where basically they used to do anterior surgery for all the patients. And there was one group in Korea, okay. So it's the long-term follow-up of these 3 groups of patients from which actually all the literature has come. So one needs to know about the MRC trials, okay. So one needs to know about it, what was done, and earlier the whole treatment was in hospital, okay, and then it became domiciliary, right? So you need to kind of look at this and understand this aspect very carefully. Of course, now we are dealing with another problem, drug resistance. So you have to understand that if asked in the exam, it is better that you tell that I will ask for a tissue diagnosis, CT guided or ultrasound guided, or on C-arm, I will confirm with a histopathology examination, I will confirm with a gene expert and a culture. The advantage of the gene expert is you get the report in 24 hours. So you will understand if it's rifampicin sensitive or rifampicin resistant. If it's rifampicin sensitive, then you will start first line AKT after 24 hours. If it's rifampicin resistant, then you will involve the pediatrician so that they can decide to start the appropriate chemotherapy, because second line AKT is beyond the purview of or knowledge of most orthopedic surgeons. At least I don't treat, some people would, but I don't, because I think they are more competent than us in managing. And then decisions on how long the AKT needs to be continued. You have to know all the RNTCP guidelines. No, there is no longer any role for alternate day chemotherapy. It is daily administered only, all right? There is literature now to suggest, that even 6 months of AKT is sufficient. So Dr. Nene has recently published a trial in adults, where they did a RCT in Hinduja comparing 9 months, 1 year versus 6 months, and they found that even 6 months AKT was effective. But that was in adult literature. We don't have enough in, pediatrics, but usually you would say 1 year of AKT. What is the differential diagnosis? So suppose you see this X-ray, and now you can put up the MRI if you want. Can you put up